I want to welcome you to UofL Physicians Lunch and Learn. I'm Elizabeth Walden, the Communications Manager for UofL Physicians, and we have Dr. Gerald Lee here with us today, and he's a physician with UofL Physicians, and he's board certified in internal medicine, pediatrics, and allergy and immunology, and he's going to talk with us today about childhood asthma and avoiding the September epidemic.
All right, thank you, Elizabeth. So again, I have to apologize for my tardiness. So again, let's get started. So I have no really disclosures for the talk, but obviously, we all know the asthma is a big problem in this country. Since we're talking about what we're focusing the discussion on, we're talking about a very common obstructive lung disease that afflicts millions of patients in the United States. As you know, it is caused by inflammation of the airway, and I'll make this pointer show up so we can see it visibly. And so, as you know, as air goes in and out of the lungs, it will have laminar flow through these airways that usually have very good caliber. Now, again, with the chronic inflammation that occurs in asthma, there is thickening, there is mucus production, and the surrounding muscles around the airway can get inflamed. And so that's the bronchoconstriction that causes that acute asthma attack that's triggered by certain exposure. So really, that would be manifested, as you know, by tightening of the chest, shortness of breath, and wheezing. And the root cause of this is inflammation, leading to that sensitivity to certain triggers. And when we think about asthma, it's so much in the news in terms, certainly a big problem at Coast Children's Hospital because it is a major health problem. And at least if we talk about children, it afflicts 1 in 11 children in the United States based on 2010 data, 1 in 12 adults as well. And so if you think about the burden on society, that would be 10.5 million days of lost school due to asthma flare-ups or exacerbations, where unfortunately 1 in 5 children, based on 2008 data, had to go to the emergency department for an asthma attack. So I'm very interested as an asthma specialist to not only maintain normal quality of life and keep kids out of the hospital, but also reduce the burden in terms of loss in school and education and so on. So unfortunately, asthma is a disease that we think has been increasing since the 1980s. The reason that this is broken is that the methodology of the survey changed based on the National Health Interview Survey. But certainly if you look at more recent data in terms of current asthma, i.e. have you had a problem in the last year, or have you ever had problems with asthma, the general trend with children and adults that this is a problem that continues to increase in the United States population. And Kentucky is particularly affected, where we have prevalence rates around the 9.5 to 10.5% range in our state. So luckily, the exacerbation rate we've done a better job on, and if we look at actual children who have been hospitalized for asthma, that has been decreasing the past 10 years, with children unfortunately overall being more admitted to the hospital than adults. But interestingly, if you break down hospitalizations that occur, there's this peculiar increase in hospitalizations that occur pretty much right now in the month of September. So this is a Canadian study where they analyzed childhood asthma hospitalizations. And so if one is defined as the mean hospitalization rate amongst the entire year, there's almost a 2 to 3 time fold increase in the rate of hospitalizations that occurs this month, the month of September. This data has been replicated in multiple countries, including the United States. And certainly the timing, the peak, is very consistent. It usually occurs between 2 to 3 weeks after Labor Day in school-aged children. So this is a very peculiar observation, and certainly most asthma specialists are quite mindful of this. So really the purpose of this talk is how can we address this very well-known trigger for asthma when we're trying to help our children. This is kind of longitudinal data showing that this pattern has been consistent for many years. This is data going back to 1990. The same peak occurs every single year in September. So why September, right? That's the question. If we know what's going on, we could possibly do some sort of intervention to prevent this. Several hypotheses have been proposed for this. I'd like to review some of the data on each of these. Certainly, we know about seasonal allergies. I'll talk a little bit about that. Number two, could pollution have a role in this? Maybe there's some less use of asthma medicines. You know, it's the summer. You know, you're not on a schedule, maybe you're going on vacation or so on. And then we'll talk about maybe it has something to do with school. We're talking about school-age children. What's the relationship with school? So let's talk about each one. Well, first of all, pollen is very seasonal. There's kind of stereotyped months where you notice each pollen species in the air. The pollen season officially starts in Louisville when it gets warm around February. That's the tree pollen season that usually peaks in the mid-spring and usually dies off by the summer. But pretty much just as this is about to die off, you're really in the peak of the grass pollen season. That's usually around April-ish, and that's usually gone around July. Now, most patients right before school have a respite where actually there's not a lot of pollen in the air. But really, we're right in the peak ragweed pollen season right now. So weed pollen season was detectable in Louisville at the last week of August. So this is a pollen counter data for Louisville. It's on the East End, and it's basically, the machine basically captures pollen in the air, and it's microscopically analyzed to see what's available. And basically you can see this kind of red-orange area here is defined as high concentration. So you can see weeds creeping up here and in full force. I'm not showing you September data, but it looks all orange, right? It's pretty much, we're in the peak of that season right now. So, you know, what do we know about ragweed? So ragweed is a weed that grows in rural areas, sides of the road, riverbanks, and so on. And it's again, releases its pollen in the late summer and fall. And it certainly does release pollen. It's been documented that one ragweed plant can release 1 billion pollen grains, which is just a number you can't even conceptualize. And those plants can, the wind can carry those pollens miles and miles away. We could be getting ragweed pollen from all the neighboring states in the country. You know, people tell me, well, I guess I'm allergic to grass or the tree, so I'll just cut down the tree. Well, you'd have to cut down that tree, the tree of your neighbors, and the tree of the entire kind of Indiana, Kentucky area. I mean, pollen is airborne, it travels long distances, and so certainly it's something, unfortunately, we're not able to escape. And you are actually in the hotbed of fall allergies. So this is a survey that's done every year by the Asthma and Allergy Foundation of America. The methodologies, they look at pollen counts, medication use, and so on. And as you can see, in 2012, we were #1. All right, so anyways, that unfortunately is the dubious honor of the Ohio Valley to which we live in. Now, kind of switching gears, you know, I'm sure we've all enjoyed a nice, you know, beautiful day in Louisville, but unfortunately, sometimes when it gets very warm during the summer, we have days like this. So very kind of foggy, smoggy days. And unfortunately, Louisville, unfortunately, is notorious for air quality. At least in the last 2 years, we've had very, very high number of days where the ambient pollution exceeded the air quality standards. And so, again, I think this year's going to be a lot better. It's been a lot cooler. But again, that is another thing that is associated with the warm months, such as summer. And the air quality index actually measures multiple air pollutants, with particulate matter and ozone being most relevant to Louisville. And based on the detectable concentrations of these in the air, the general number where something around 100 or above is considered unhealthy for sensitive groups, and that defines patients with asthma. Asthma is considered one of those susceptible populations that are sensitive to significant pollutant exposure. And so I'm giving you a lot of Louisville data. What is the state of pollutants if you look at national rankings. So the American Lung Association polls, I think, about 300 to 400 metropolitan areas for these pollutants. And actually, if you look at ozone days, where our ozone exceeded the recommended amount, we are number 17 in the country. You know, you think of LA or something, you know, California, actually we are up there with those cities. Now again, for particulate matter pollution, again, when you think of particles, think of like car exhaust or the trucks. And one peak 24-hour period, we're 41. But if you look at the year-round average throughout the year, we are number 12. Number 12. And so, again, these are cofactors that can exacerbate allergies and asthma. And why is that a prevalent problem in Louisville? Because we have a lot of highways and cars, and certainly we have power plants as well. Those release nitric oxide and other volatile organic chemicals. Now, those in itself shouldn't cause a lot of problems until you mix sunlight into the picture. So if you have peak traffic volumes, and then mix in a very hot, warm summer day, a biochemical reaction where the heat and sunlight will convert this to ground level ozone, which has been shown to be a significant respiratory irritant to patients with asthma. And so really it's the kind of combination of all the highways that exist through Louisville. We are a major transportation hub through UPS, or just basically truckers going northwest in east and south. East, west, and north and south. And certainly a lot of our parks and so on are right by the highway, and that's kind of where we live. So again, exposure is quite relevant for our city, given the kind of the spaghetti junction and so on. Now, interestingly, pollution levels don't actually peak in September. They actually peak, as you'd expect, in the warmest, hottest months. This is the 5-year trend since 2009. Again, we don't have complete 2013 data on this graph, but as you can imagine, this is the time prior to the start of the September epidemic where, again, ongoing asthma inflammation could be going at a baseline rate where, again, we are exposed to agents that could be contributing to that thickening and inflammation due to asthma. Now, I mentioned a little bit about controller use. We actually have data from this, so a lot of it is Canadian data, but if you look at prescription refill data, they actually drop during the summer months. I think this also has been replicated in other cities, and I really feel it is due to this kind of disruption of routine, and you're going on vacation, you're not going to see the doctor as much. And so sometimes who had severe asthma versus kids who had the same severity but didn't go to the ED. And the kids who required an ED visit for asthma had higher percentage of rhinovirus and other virus detected based on PCR testing. So the rhinovirus infection, we think, is the spark that actually lands the kids in the hospital. And again, now everything I've talked about is relevant, but really that uptick is most likely due to some sort of exposure to a viral infection. Now, the kids who ended up in the ER, they actually had less prescriptions for inhaled steroids or montelukast, suggesting that medical therapy can modify your risk despite exposure to infection, that you're not destined to go to the emergency department. So allergic disease and viruses have been shown to interact in certain studies. A particular study found that children who had allergic asthma versus non-allergic asthma, the allergic children had longer upper respiratory tract infections, and they had greater severity as well. So again, the allergen may not be the spark that leads to that uptick, but certainly creates the environment that makes it more severe than it should have been. So let's put this all together. How would we define everything we know about the September epidemic? Well, again, I've showed you the factors, and they all seem to play together. I would say that the raw fuel for what we're observing is presence of large ragweed pollen counts causing inflammation in the lung. Pollution, maybe they developed a lot of inflammation during the summer months prior to the start of school, going outside and exposed to ground level ozone and particulate matter. And then again, vacation, a loss of routine, and that inflammation is not being treated, all right? So that's kind of the setup for the spark. And unfortunately, the spark is rhinovirus infections and other respiratory infections that have been attributed to exposure to other classmates in school. And that leads to an asthma attack, unfortunately. So we know what causes the September epidemic. There is very strong data that correlates all these factors together to create this perfect storm. What are the interventions we can do to protect our children? Unfortunately, we have not yet have an effective vaccine for rhinovirus, the #1 cause of viral infections. But other viruses certainly can cause asthma exacerbations, and there's one we definitely can do something about, and that's influenza. So influenza vaccine in some studies have been shown to reduce exacerbations due to asthma. So there is positive data out there that despite us not being able to intervene on the common cold, we can intervene on influenza to protect our kids and keep them out of the ER. Similarly, I told you ongoing inflammation could be the setup to developing exacerbations in September. So how would we assess what kind of inflammation is going on? Will we assess that using standardized questionnaires, common questionnaires, the asthma control test? And that's the doctor would ask you that. And then we can formally test the lung. It's very interesting. There's a group of patients out there who actually have poor perception of symptoms. I've had patients in my office who had very low lung functions, but they say that they're fine, that they don't feel anything. And you know, that probably has to do with what they're doing, right? If you're the kind of kid who kind of plays video games and don't challenge the young lungs, you can tolerate a pretty severe airway dysfunction without feeling anything, and they'll never report symptoms in that regard. So actually a formal breathing test will help us inform whether our child is at risk prior to the start of school or at the beginning of September. And actually the general recommendation based on the National Heart, Lung, and Blood Institute guidelines is that we do this assessment every 3 to 6 months. So obviously I talked a lot about medicines and the importance of if you do have uncontrolled inflammation that we have to deliver medicine to open up those airways and allow normal lung function so that if you do get that second hit like an infection, you're starting from good airway, baseline airway function versus at a lower place where that you hit a certain threshold that will lead you to go to the emergency department. So again, multiple options are available. And I want to emphasize the importance of also treating upper airway disease. There is a relationship between the upper and lower, and we feel that yes, a lot of people with asthma, we focus on lower airway disease, but there's evidence to suggest that uncontrolled nasal symptoms can make asthma worse, and vice versa. Allergies can be worse if the lower airway inflammation is diseased. The respiratory system is one unit, and therefore being mindful of both components, control of nasal congestion, sneezing, coughing, and runny nose can help asthma, and also taking inhalers regularly can improve allergy symptoms as well. And there's experimental data to suggest that. And certainly my role as the allergist is to figure out what in the environment is triggering this inflammation, what, pollens, molds, cat's dogs, or so on, or ragweed, in the case of the September epidemic, is actually going into the nose or going into the airway. Patients come to my office. I prick them with a dermapick. It introduces the allergen. If they are allergic, they'll develop a hive-like reaction. And in 15 minutes, I can tell exactly the parent what is causing the symptoms. And that is very useful information in terms of avoidance. And if indicated, we can desensitize with allergy shots. A good resource is once I find what they're allergic to, I usually refer them to pollen.quadai.org. That's how I got